Dear friends, it's my pleasure to share with you some of the work in our center on BMD, bone qualities, and bone microarchitecture in the etiopathogenesis and prognostication of AIS. I have nothing to declare. Our multidisciplinary team in our center has incorporated a lot of different experts and clinicians. I would like to concentrate today on my talk on an overview on the bone metabolism related part. Through the years, our first publications in 1997 found that osteopenia in adolescent idiopathic scoliosis occurs in about 30% of the cases. And later on, we found out this is a systemic phenomena, and 85% of the osteopenic persist beyond skeletal maturity on longitudinal follow-up, and is also associated with curve severity. One of the latest findings a few years ago is that this phenomena on longitudinal follow-up is still persisting without any intervention. Now, with the histological studies and histomorphometry of the biopsy specimens from the iliac crest of AIS patients undergoing surgery, it's very clear that we find that the increased amount of proportion of osteoids, the lesser number of the osteocytes, and also the reduced keratinocyte expression was found in multiple specimens. And we know that bone density is not the only factor affecting the mechanical bone strength, which should be an integration of the bone mass or bone mineral density and the bone qualities. So how to assess the bone qualities? We have endeavored to use the quantitative ultrasound and demonstrated the abnormal bone qualities in AIS. We also demonstrate the quantitative ultrasound can predict curve progression in AIS. With the advent of the new machine of the 3D HRPQ-CT, which we have acquired, one of the first in the Asian countries, we are able then to make use of this Extreme CT 1 and later on 2, which have very low radiation and high resolutions. We are able to measure 11 bone quality parameters, grouped into bone morphometry, volumetric BMD, and trabecular microarchitecture. So we're published here, as shown in the diagram, a distinct difference between the AIS patients undergoing surgery and also those non-operative cases versus the control in the various compartments. Now here summarize the abnormal cortical and trabecular compartment comparing the normal versus the osteopenic AIS. This was summarized in one of the publications in 2017. We also demonstrate the abnormal bone mechanical property manifested by the stiffness failure load and apparent modulus, with a difference between the osteopenic versus the non-osteopenic group by a factor of nearly over 20%. We have found in other studies the higher bone turnover and also the increased bone resorption in the progressive AIS. We are able to show the abnormal bone remodeling in groups with a progressive curve. So the decreased cortical density and mechanical strength was found to be associated with elevated bone turnover markers at the peripubertal height velocity. Now, we also found in the BMD can predict the curve progression and also to the progressing to the surgical threshold in the newly diagnosed AIS patients. These were published in the JBJS in 2005 using DEXA alone, and 2016 using the DEXA together with the HRPQ-CT, which demonstrate an increased surgical risk of 2.3 if the cortical bone porosity was actually above a certain threshold. And to further enhance this study, we use unsupervised machine learning system to analyze all the 11 HRPQ-CT bone microarchitecture data and to find some of the things that we are not able to analyze with the usual conventional technique. This is a new unpublished data. We're able to demonstrate three clearly distinguished clusters of bone microarchitectural phenotypes identified by the machine learning. So this is the phenotype 1, 2, and 3. Particularly the 3 is with a low cortical volumetric BMD and compromised trabecular microarchitecture. This is a longitudinal study. We found that all the three clusters, they did not change, and they persisted to skeletal maturity and beyond without any intervention. It is interesting to find that in the survival analysis, we find that the phenotype 3 is associated with a 4 times adjusted hazard ratio of progressing to 50-degree or more and reaching the surgical threshold, even after adjustment of the other parameters. So these observations cause us to think about what are the causes, the mechanism contributing for the abnormal bone matrix mineralization and bone qualities. So we venture to go into the osteoblast studies class and osteocytes, and we find focusing on the osteocyte seems to be the missing link to the abnormal bone qualities in AIS. The new enabling research tools and available from our center and also our collaborators allow us to go into depth the study of the osteocytes. Using acid etch, the SEM image, in collaboration with the Texas group, we're able to identify in control versus the AIS the very much abnormal clusters of disorganized alignment and distribution of abnormal osteocyte lacunae in the AIS, as you can see here in the picture. Now, we broke it up to 1,000 times. You see the orderly alignment of all the osteocytes and dendrites in the control group versus the irregular osteocyte lacuna morphology in size and also the shape, and also with the shortened and disorganized canalicular and the shortened dendrites. To break it up to 2,500 times is clearer control osteocytes versus the AIS osteocytes with the shortened and disorganized dendrites, and also the cell shape is different. Using the stacked confocal imaging again shows the distinct difference between the control group and also the AIS patients, which are quantitatively measurable with the fewer shorter canalicular per nacular up to about 10-20% or more differences. And this has been reported in different studies and publications. One of the latest publications this year is the abnormal morphological picture using a large-scale assessment of over 300,000 osteocyte lacuna. We were also shown that we are able to culture the osteocyte from the patient using a 3D primary osteocyte culture, which allow us to see the dendritic structures and also the mature molecular expressions. That opens up many new area of research possible. So we focus also on the aberrant mere RNA 145. This is collaboration with Alan Mohore's St. Justin's group, Montreal group, and we also reported on the MIR 95. And this is a paper published in the Lancet eClinical Medicine, a validated composite model incorporating the clinical parameters together with the bone resorption and the MIR 145 data. A key summary of the findings so far is osteopenia in 30 to 40% of AIS, abnormal bone geometry, microarchitecture, mineralization, bone turnover, remodeling, mechanical strength, abnormal osteocyte canalicular system, osteopathogenesis, and all these are significant prognostic factor for curve progression and progression to surgical threshold. So we asked, is the abnormal bone qualities linked to lifestyle factors in AIS, and could the curve progression be reduced by improving the bone qualities through the lifestyle modifications? This is a randomized double-blind placebo-controlled trial led by TP Lam in preventing the curve progression with calcium and vitamin D supplementation. This has won in 2016 the best clinical paper both in the PostNet and SRS, and extended 6 years longitudinal follow-up of the same study. The current finding, the early analysis shows that this dosage of vitamin D and calcium supplement can improve the bone density and all the parameters, prevent the curve progression. Now, even with 2 years of supplement at a critical growth period could yield positive results at or beyond skeletal maturity. So we find that we are strong belief that the genetic factors probably contribute to the onset of the AIS, while the environmental factors will have a much more important role to play in the progression of the curve. we need to thank all our collaborators locally and internationally for all the support over the years.